Hello viewers, I am Dr. Raviul. I work as a lecturer of pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is chronic lymphocytic leukemia. This is the fourth lecture of our leukemia series, and in this lecture we will learn about introduction and definition of chronic lymphocytic leukemia, the World Health Organization classification of lymphoid neoplasm. We will also talk briefly regarding the pathogenesis of this disorder, its clinical feature, laboratory diagnosis, prognosis, and towards the end of today's lecture, we will also talk briefly about its treatment. Okay, a lot of topics, so let's begin. And we will start by talking about some introductory points regarding chronic lymphocytic leukemia. Chronic lymphocytic leukemia is the most common form of leukemia of adults in Europe and also in the United States. However, it is less frequent elsewhere. The median age of diagnosis is about 60 years. It is twice as common in males as compared to females, and as we will see, it is an incurable disease and it tends to run a chronic and fluctuating course. So, how can we define chronic lymphocytic leukemia? It can be defined as neoplastic disorder characterized by monoclonal proliferation of immunologically incompetent and slowly dividing mature B lymphocytes. Now, what do we mean by this term, monoclonal proliferation? It is a group of cells that are produced from a single ancestral cell by repeated cellular replication. And to diagnose a case as chronic lymphocytic leukemia, there must be monoclonal B cell count more than 5 × 10⁹ per liter or 5,000 per microliter. So now let's talk briefly about the World Health Organization classification of lymphoid neoplasm to see where chronic lymphocytic leukemia is located in this classification. Now, in the World Health Organization classification of lymphoid neoplasm, the term chronic lymphocytic leukemia and small lymphocytic lymphoma are placed in the group called peripheral B-cell neoplasm. So this is the World Health Organization classification of lymphoid neoplasms. We can see that in this classification, lymphoid neoplasms are classified under 5 broad headings. They are precursor B-cell neoplasms, peripheral B-cell neoplasms, precursor T-cell neoplasms, peripheral T-cell and natural killer cell neoplasms, and the last group is Hodgkin lymphoma. And we can see that example of precursor B-cell neoplasms will include B-cell acute lymphoblastic leukemia or lymphoma. And in the example of peripheral B-cell neoplasms, we can see at the top there is chronic lymphocytic leukemia or small lymphocytic lymphoma. But also we can see that in this group of peripheral B-cell neoplasms, there are a lot of other lymphomas and leukemias as well. So we can see that the World Health Organization classification considers chronic lymphocytic leukemia and small lymphocytic lymphoma as one entity with different clinical presentation. For example, in chronic lymphocytic leukemia, there is primarily involvement of the bone marrow and peripheral blood, and in case of small lymphocytic lymphoma, that mainly involves lymph nodes and other lymphoid organs. So now let's talk about the pathogenesis of chronic lymphocytic leukemia. Now always remember, chronic lymphocytic leukemia or small lymphocytic lymphoma is a slowly growing tumor, and in the pathogenesis, tumor cell survival seems to be of more importance compared to tumor cell proliferation. Now always remember, here the tumor cells contain high levels of BCL2 protein that inhibit apoptosis. Now I have a separate video entirely on apoptosis, and you can also watch that video after finishing this lecture to know more about apoptosis. So what is happening here? Chromosomal deletion will lead to loss of certain genes that used to encode certain microRNAs that were negative regulators of BCL2 protein. So what will happen when there is loss of negative regulators of BCL2 protein? It is obvious there will be increase in the level of BCL2 proteins, and that will inhibit apoptosis. And when there is inhibition of apoptosis, that will increase the survival of those tumor cells. Again, signals generated by B-cell receptors, which are in fact surface immunoglobulins, will cause expression of certain genes that will also promote survival of the tumor cells. Another mechanism is that when there is accumulation of tumor cells, that will also cause suppression of the normal B-cell function. So now that we have talked about the pathogenesis, now let's move on and talk about the clinical features of chronic lymphocytic leukemia. The condition may remain asymptomatic, it may have an insidious onset, and it may present with non-specific clinical features. So this slide is summarizing the common clinical features. They will include anemia, enlargement of lymph node or lymphadenopathy, enlargement of the spleen or splenomegaly, enlargement of liver or hepatomegaly, hemorrhagic manifestations, and susceptibility to infections. So why will there be anemia? Anemia develops due to progressive replacement of the bone marrow by the tumor cells, and it may also develop due to hypersplenism and also due to autoimmune hemolysis. Regarding enlargement of superficial lymph node, always remember that it is a common finding, and the lymph nodes are usually non-tender, symmetrically enlarged, and discrete. Regarding hemorrhagic manifestations, we will see that in case of chronic lymphocytic leukemia with thrombocytopenia, hemorrhagic manifestations are seen. Regarding susceptibility to infection, always remember that there will be increased susceptibility to infection due to replacement of bone marrow by tumor cells, because those tumor cells are immunologically incompetent, and they will also cause hypogammaglobulinemia, that is, reduction in the number of immunoglobulins in the blood. So now let's discuss the laboratory diagnosis, and let's see how can we diagnose this disease. Now the diagnosis is based on peripheral blood picture, bone marrow examination, immunophenotyping, cytogenetic analysis, and immunological studies. In the peripheral blood picture, we will see that the red blood cells will show normocytic normochromic anemia. That means the size of the red cells will be normal, and also the central pallor will be 1/3. So that is also normal. So that's why we are saying that the red blood cells will be normocytic, normochromic. However, there will be reduction in their number that will lead to anemia. Anemia is usually mild to moderate in nature. The total white blood cell count will be elevated, and it will be usually from 50,000 to 200,000 per microliter. So there will be marked leukocytosis. However, it will be less than that is seen in case of chronic myeloid leukemia. Typically, more than 90% of the leukocytes are mature small lymphocytes, and there will be also presence of smudge cells or basket cells, which are in fact degenerated forms of the tumor cells, and they are seen due to damaged nuclei of the fragile malignant lymphocytes. Platelet count may be normal, however, in certain cases they may be moderately reduced as well. So here we can see a simple diagrammatic image that is denoting the peripheral blood film of a patient with chronic lymphocytic leukemia. So in this image, this cell is small mature looking lymphocyte. These tiny dots are denoting platelet. This is a red blood cell, and we can see that the red blood cell is normocytic and normochromic because it is normal in size, which is roughly about the size of small lymphocytes nucleus, and also the central pallor is 1/3, that is also feature of normochromic cell. Okay, so that's why we are saying that this red blood cell is normocytic and normochromic. If the central pallor was more than 1/3, then we would have said that the red blood cell has become hypochromic. And what is this thing? This is the smudge cell. This is in fact degenerated form of those neoplastic cells. Now, 4 patterns of infiltration can be recognized on bone marrow trephine biopsy. They will include interstitial pattern, nodular pattern, diffuse pattern, and mixed pattern. What do we mean by interstitial pattern? Here, individual neoplastic cells will be found interspersed between hematopoietic cells and fat cells of the bone marrow. What do we mean by nodular pattern? Here, well-defined round or oval aggregates of neoplastic cells will be seen, and they are located in non-paratrabecular region. And what do we mean by this term? Diffuse pattern. There will be extensive replacement of both hematopoietic cells and fat cells of the bone marrow, and that will result in loss of bone marrow architecture, which is also called effacement of bone marrow architecture, and the bone marrow will appear packed. In the mixed pattern, there is usually combination of the nodular and interstitial pattern. So in this slide, the top image is denoting the normal bone marrow architecture. So these are the fat cells that are drawn in white color. These are the trabeculae, and these are the hematopoietic elements. Actually, although the hematopoietic elements are drawn here in a single color, but always remember, actually, these are composed of various hematopoietic cells. To keep this diagram simple, we didn't draw the individual cells, otherwise the image will become very complex. Now, on the bottom we can see another image, and that is denoting the interstitial pattern of chronic lymphocytic leukemia. Note that these are the individual neoplastic cells that are dispersed between the hematopoietic elements and fat cells. In this slide, we can see the nodular pattern and diffuse pattern of chronic lymphocytic leukemia. Note that regarding the nodular pattern, we can see that here the neoplastic cells have formed nodules or aggregates that are non-paratrabecular in distribution. So they are not located around the trabecula, they are located in between the trabecula, and they are forming nodules or aggregates. And in the bottom we can see the diffuse pattern, and here we can see that the entire architecture of the bone marrow has been lost, and that's why it is said that there is effacement of the bone marrow architecture, and the bone marrow seems tightly packed with neoplastic cells. Immunophenotyping provides definitive diagnosis. It should be done in all cases before beginning the therapy, and chronic lymphocytic leukemia cells usually express phenotype of early B cells. The tumor cells express CD19, CD20, although weakly, CD5, CD23, and weak surface membrane immunoglobulin. A single light chain, either kappa or lambda, is expressed on the surface of the tumor cells. Regarding cytogenetics, there is no single cytogenetic abnormality that is specific for chronic lymphocytic leukemia. The common abnormalities will include deletion of the long arm of chromosome 13. Note that here 13 is denoting the chromosome number, Q is denoting the long arm, and the minus is denoting deletion. So the common abnormalities will include deletion of the long arm of chromosome 13, deletion of the long arm of chromosome 11, trisomy 12, deletion of the short arm of chromosome 17, and complex abnormalities. Some chromosomal abnormalities are associated with a poor outcome. For example, deletion of the long arm of chromosome 11 or deletion of the short arm of chromosome 17. These are associated with poor outcome. Regarding immunological studies, always remember in 2/3 of the patients, hypogammaglobulinemia, that is reduced number of immunoglobulin in the blood, is seen. It may be severe as the disease is progressing, and in about 5% of the patients, a monoclonal protein called M-band is also observed. So now that we have talked about the laboratory diagnosis, now let's move on and discuss briefly the prognosis. Regarding prognosis, always remember chronic lymphocytic leukemia is a diverse disease in terms of clinical behavior. Over the years, a variety of features have been used to predict the prognosis. Now, one particular thing that you need to know in order to understand the prognosis of this disorder is the staging of chronic lymphocytic leukemia. There are two different systems for staging. One is the Rai system that is used more often in the United States, and the other system is Binet system that is used more widely in Europe. Note that the T at the end of this word Binet is silent. Actually, this is a French name, and that's why you have to pronounce that like that and not say Binet. So the correct pronunciation should be Binet. Now, this slide is showing the staging of chronic lymphocytic leukemia according to the Rai classification, and according to this classification we can see that we can classify chronic lymphocytic leukemia in 5 stages. They are stage 0, 1, 2, 3, and 4. So what's happening in these various stages? Now in stage 0, there is absolute lymphocytosis, and the number of lymphocytes should be more than 5 × 10⁹ per liter. In stage 1, what will happen in stage 1? There is also absolute lymphocytosis just like stage 0. However, there is also enlargement of the lymph nodes or lymphadenopathy. Moving on to stage 2, we can see that there will be also absolute lymphocytosis more than 5 × 10⁹ per liter, plus there will be enlargement of liver or spleen, and there may or may not be enlargement of the lymph nodes or adenopathy. Moving on to stage 3, there will be absolute lymphocytosis more than 5 × 10⁹ per liter, and also there will be anemia, and enlargement of lymph node and other organ enlargement may or may not be present. In the 4th stage, actually this is the 5th stage, but it is denoted as stage 4 because we are starting with 0. So what is happening in stage 4? There is absolute lymphocytosis. Lymphocyte count is more than 5 × 10⁹ per liter. There is also thrombocytopenia, and enlargement of the lymph node and enlargement of organ may or may not be present. Now, when determining the treatment options, physicians will separate the Rai stage into low, intermediate, and high-risk groups. So we can see that stage 0 is considered low risk, stages 1 and 2 are of intermediate risk, and stages 3 and 4 are considered high risk. So this slide is showing the staging of chronic lymphocytic leukemia according to the Binet classification. Here, chronic lymphocytic leukemia is classified by the number of affected lymphoid tissue groups and also by whether or not the patient has anemia or thrombocytopenia. Now, whenever we are mentioning this term, affected lymphoid tissue groups, you should remember that in this classification, affected lymphoid tissue groups will include the neck lymph nodes, inguinal lymph nodes, axillary lymph nodes, and also spleen and liver. So in case of stage A, we will see that there will be involvement of up to 2 areas. However, there will be no anemia and there will be no thrombocytopenia. Moving on to stage B, in this stage, 3, 4, or 5 areas of lymphoid tissue groups may be involved, but still there will be no anemia and no thrombocytopenia. And in case of stage C, the organ enlargement is not considered, but there will be reduction in the hemoglobin and also in the platelet count, so there will be anemia and thrombocytopenia. As we can see, stage A has low risk and stage B and C have high risk. Now, these staging systems cannot accurately predict, particularly in the early stages, whether a patient will have disease progression or whether the patient will have indolent disease. So other prognostic markers are also helpful. Recently, a growing number of biological and molecular markers are being used for more accurate assessment of the disease status and prognosis. They will include somatic mutation status of the variable region of the immunoglobulin heavy chain and also presence of chromosomal abnormalities. Now, somatic mutation status of the variable region of the immunoglobulin heavy chain can divide the disease into 2 groups. About 55% of the chronic lymphocytic leukemia patients have mutated immunoglobulin heavy chain, and they will have indolent disease, and median survival time is about 24 years. On the other hand, chronic lymphocytic leukemia patients with unmutated immunoglobulin heavy chain will have aggressive disease and median survival time is about 8 years. So in this slide we can see the prognosis that is related to presence of various chromosomal abnormalities. We can see that deletion of the long arm of chromosome 13 has good prognosis. Deletion of the long arm of chromosome 11 has poor prognosis, trisomy 12 has intermediate prognosis, and deletion of the short arm of chromosome 17 is related with very poor prognosis. So now that we have discussed the prognosis of this disorder, now let's move on and discuss briefly its treatment. Now, in the first slide of today's lecture, we had already seen that chronic lymphocytic leukemia is an incurable disease, and therefore the treatment approach is generally conservative. With optimal management, patient can usually lead a relatively normal life for several years. Aim of the treatment is symptom control rather than a normal blood count. Again, many patients never need treatment. Treatment is given for troublesome enlarged lymph nodes or spleen and when constitutional symptoms such as weight loss or bone marrow suppression are present. Now, various forms of therapy for suppression of the disease are available. They will include chemotherapy, corticosteroids, radiotherapy, and immunoglobulin replacement. So let's talk about these options. Now, regarding chemotherapy, always remember, for many years the treatment has been based on combination of cytotoxic drugs such as fludarabine, chlorambucil, and cyclophosphamide or bendamustine, together with a monoclonal antibody against CD20, for example rituximab. Now, these agents are given together every 4 to 6 weeks. In older or less fit patients, a less intensive treatment plan is provided. However, that will still involve chemotherapy and also the anti-CD20 antibody. Regarding corticosteroids, these are helpful for treatment of autoimmune hemolytic anemia and also for immune thrombocytopenia that are sometimes present with chronic lymphocytic leukemia. Splenectomy is also indicated in certain cases of chronic lymphocytic leukemia with autoimmune hemolytic anemia. Now, regarding radiotherapy, it is given for treatment of splenic or lymph node enlargement that is causing compression problems. Regarding immunoglobulin replacement, these are useful for patients with hypogammaglobulinemia and who are suffering from recurrent infections, particularly during the winter months. So this concludes our lecture on chronic lymphocytic leukemia. I hope this video was helpful. If you like my videos, do comment, share, subscribe, and let me know. And for my students, I will also recommend you to go through your textbooks to know more. Okay, that's all for today. Until next time, take care and stay blessed. Thank you.